So the newborn screening is a very important tool, and hypothyroidism and phenylketonuria are the two primary diseases that were screened, and subsequently multiple conditions have been added. We nearly have 40 to 50 conditions now. So early diagnosis and treatment ameliorate severe cognitive problems in congenital hypothyroidism. This is beyond doubt. Earlier we diagnose, the better. So the newborn screen should be done ideally before the patient goes home. The vaginal delivery patients often go home by 24 to 36 hours. So to avoid missing out, we send the sample early, even though there is a slight increase in the false positive. But with the cutoff in the lab changing, we are not seeing that issue. And the heel prick test is done by day 3 to 5 or even earlier, as I discussed. And it's based on identifying TSH level elevation on whole blood on a filter paper card. So all of you would be familiar with the filter paper test. Wherever you work, you should be able to link up with the lab in the region. You just need a system to collect the samples and send it together. Even if you're in a remote setting, the labs can support you by coming, and courier can help you with that as well. So where there is a will, there is a way. So don't blame the system. Try to find a way in which your deliveries, the babies you deliver, can have newborn screening. And because the labs do it on multiple samples, you can have it fairly cheap as well. You can negotiate a good rate depending on the number of cases you have. The TSH threshold of 10 units is used mostly, but if your lab is sending samples earlier, you can have a higher cutoff for the first 3-day sample. So the age of the sample is very important as well. So most of the newborn screening in different countries have a primary TSH with backup of T4, which can be screened if TSH comes abnormal. This option is not available in all the labs, so be familiar with what your lab has. There can be false negative newborn screening in central hypothyroidism, as we discussed, and there can be a delayed TSH elevation in hypothyroxanemia, low birth weight babies, thyroid binding globulin deficiency. So you cannot be sure that you picked up these. So if there is a clinical concern like prolonged jaundice, you still need to do the full thyroid function test, even if the TSH was normal on the newborn screen. Some countries have primary T4 with a backup TSH. Here we can identify thyroid binding globulin deficiency, central hypothyroidism, hypo and hyperthyroxanemia as well. However, it misses compensated hypothyroidism, where the TSH may be high, but the thyroid gland is working harder to produce a T4, which is in the normal range. And the patients who have initial normal T4 and delayed TSH increase, as well as transient hyperthyroidropenia, may be missed. Combined primary TSH plus T4 is ideal, but not practical due to the cost implications. So most labs use primary TSH in the newborn screen. You may have a false negative screen if the sample is insufficient or inadequate, especially the spot sample if it's not dried and stored properly. Prematurity is one of the reasons where immaturity of the pituitary axis may cause acute illness. Exposure to iodine-containing compounds is more common. However, most of the NICUs have moved away from using betadine for premature babies, and preoperative preparation as well. We don't use betadine in premature babies. So there can be a delayed postnatal elevation in TSH, and blood transfusion can be a factor as well. So ideally, the newborn screening sample should be taken before blood transfusion, and if your baby is on TPN, you take a 0 sample, and then after the TPN finishes in a premature baby, you repeat the sample. False positive screening can happen if sampling is too early because of the TSH surge. If the blood spot is multi-layered, it can cause problems, and transient hypothyroidism can be there due to prematurity, due to the immature thyroid function, acute illness, use of drugs. Maternal antibodies can stimulate the thyroid, and maternal iodine supplements can impact as well. And as I said, iodine-containing compounds can also cause increased production. And maternal iodine deficiency can stimulate the fetal thyroid gland as well. So in terms of abnormal newborn screen, so if the level is more than 40, start treatment soon after obtaining the venous sample. In real life, sample and the result mostly available on the same day. So in most cases, you can wait for the result, but remember that it's very urgent, and picking up the result, contacting the patient, and responding immediately is very important. Every hospital should have a system where the newborn screen gets fed back, and there shouldn't be even a day's delay in reporting the results. So you should have a system over the weekend. You should have a system apart from the named consultant. Who else will get the report if a consultant is on leave? An email system involving the full team is a good option, but email alone is not enough. It should be a critical report from the lab so that the team is alerted and immediate action is taken. And parents also have a responsibility in giving alternative contact number or email options and so on. So sometimes a mother is too tired after the delivery, she doesn't pick up in the first 3-4 days, so dad's number is essential. So think about these aspects as well, so we don't delay any case. And once the thyroid is confirmed as abnormal, treatment is started. Then you confirm by radioisotope scanning or scintigraphy. This is not in all the guidelines. Ultrasound is suggested in all guidelines, but you may miss ectopic thyroid or a small focus of functioning thyroid on ultrasound. So radioisotope scanning can be considered before the treatment is well established, so within 5 days of starting treatment, but don't delay initiation of treatment for imaging purpose. So if the TSH is less than 6, it's normal and no need to treat. And remember that in babies, in the initial days, there is a surge, and 6 to 20 is not very abnormal. So if the baby is more than 21 days, then you investigate, and if it's free T4 is normal, you consider withholding treatment for 2 weeks and then retesting. So if it is 6 to 20, most of the time we repeat by 10 to 14 days, and if it's improving, we don't need to worry. If it's worsening, you start treatment. And if you happen to do it by 21 days, even with the normal newborn screen less than 6, then you may consider treating them as well. If it is more than 20, it's preferable to commence treatment even if the free T4 is normal. However, if it is trending down, you can wait a week or so if the T4 is normal. So this is the part that we will discuss later as hyperthyroidropenemia, where it's not clear cut whether to treat immediately